Good evening. This YouTube video provides a high-level, actionable update on renal failure management based on 2026 guidelines. The new landscape of kidney failure. Forget what you learned 5 years ago. 2026 guidelines have fundamentally shifted how we treat kidney failure. The shift, moving from just managing complications to disease-modifying therapies. Key update: DIGO 2026 guidelines emphasize earlier identification, personalized pharmacological strategies, and the merging of AKI, acute kidney injury, and CKD, chronic kidney disease, management. Goal: slowing progression, not just managing numbers. 2. Chronic kidney disease, CKD, management, the 4 pillars. The 4 pillars of modern CKD care. RAS inhibitors, ACE inhibitors or ARBs, first line for BP and proteinuria. SGLT2 inhibitors, e.g., dapagliflozin/Jardiance, essential to reduce progression even in non-diabetics. GLP-1 agonists, e.g., Ozempic/semaglutide, newly approved for 24% reduced risk in kidney progression in diabetic CKD. Non-steroidal MRAs, e.g., finerenone, to reduce inflammation and scarring, especially in diabetic CKD. Key 2026 update: combining these therapies creates a synergistic protection effect, often delaying dialysis by years. 3. Acute kidney injury, AKI, and AKD updates. New definition: DIGO 2026 focuses on a continuum, AKI, 0 to 7 days, acute kidney disease, AKD, 7 to 90 days. Recovery focus: new evidence suggests that if creatinine doesn't return to within 10% of baseline by 3 months, the risk of long-term kidney failure is significantly higher. Stewardship: proactive nephrotoxin stewardship, stopping ACI/diuretics and sepsis/hypotension, is crucial. Contrast update: pre-procedure hydration with isotonic crystalloids is recommended, N-acetylcysteine is not recommended, no benefit shown. 4. Anemia and complication management updates, DIGO 2026. Anemia update: first major update since 2012. Hemoglobin targets remain 10 to 11.5 g/dl to avoid adverse cardiovascular events. New agents, HIF-PHs, hypoxia-inducible factor prolyl hydroxylase inhibitors, are an alternative to ESAs, but ESAs remain first line in many regions. Iron strategy: proactive 4-iron therapy, similar to pivotal trial approach, is preferred over reactive approaches to reduce ESA requirements, targeting ferritin up to 700 nanograms per milliliter. Hyperkalemia: new potassium binders, Potiromer/Lokelma, are used more proactively to keep patients on RAS inhibitors, rather than stopping the kidney protective drug. End-stage renal disease, ESRD, and future directions. Dialysis choice: promoting home therapies, home hemodialysis/PD, over in-center for better quality of life and outcomes. Rare diseases: new targeted therapies like Filspari, sparsentan, for IgA nephropathy. Future: gene editing, CRISPR, and stem cell research for genetic kidney disorders are moving into phase 3 trials. 6. Conclusion and key takeaways. Summary: use the 4 pillars of CKD management early: RAS, SGLT2I, GLP-1, MRA. Monitor for AKD, 3-month window, after an AKI event. Proactive iron management, conservative transfusion. Closing thought: the future of nephrology is proactive prevention. Call to action: subscribe for more in-depth medical updates. Tags: nephrology, kidney failure, DIGO 2026, AKI, CKD management, SGLT2 inhibitors, Ozempic for CKD, renal failure updates, medical education. Disclaimer: the video is for awareness purpose only and specific advice must be taken from the concerned experts in person before acting on any provided info. The creator, publisher and YouTube will not be liable for any incorrect consequences/results/self-medication.